Hello and welcome to the Auditing Antics Podcast. So today we're going to be talking about the use of different smart tools that are available inside of an EMR system. And, this is something that we experience quite a bit with various systems. So across the board, regardless of whether you're using Epic, NextGen, eClinicalWorks, Athena, there's so many different systems out there, but they all have these different capabilities. And one of the things that I've really experienced a lot of frustration with, not only on my part as an auditor and reviewer, but meeting with my physicians and the different practitioners to go over audit feedback, there's been a lot of back and forth and at sometimes anger because they're trying to really look at the administrative burden of documentation, right?
hmm
I just had a physician tell me last week that physicians are known to give very good care, but have very poor documentation. It still isn't an excuse for that. We still have to make
No.
sure that compliance is followed.
How
So
did we know you gave good care if you're not documenting that good care?
exactly. And there actually was a patient scenario involved with that particular physician. So that was interesting coming from him.
hmm
um, Sadly. But, Michelle, let's just do groundwork quick because I feel like we need to throw this caveat out there because we don't know who's going to be joining in or listening on demand in the future. But let's give the groundwork really quickly related to the compliant use. So we always get that question of, is copy and paste allowed? Because some people go to the extreme and don't allow it at all. But what are our practitioners allowed to do to be compliant with copy and paste or carrying forward?
So I always like to explain this as it is allowed to use copy and paste. However, the documentation still has to show your work of the encounter. So essentially, using this carry forward or using this copy and paste is not a replacement for the need to document your work of this current encounter. I think that is where the biggest disconnect is with copy and paste.
Mhm.
With any of these things, so I know we were going to talk about templates and things like that. Any of these tools that are available in your electronic medical record, I like to always refer back to that CMS decision table that they have out there for ensuring the proper use of electronic health record feature and capabilities. I think that's where they give the best information.
Mhm.
I guess is the best way to put that plainly
Yeah.
is in that decision table. Steph, I can send you the link to that. Um, if
Yeah, I
if
have
you
it
would like
here.
to put it up there. But in
Yeah.
this, in regards to the use of copy and paste, it says here, let me just see if I can find the exact wording here.
And one thing I want to point out too, so when you even just look at that document, they use the word integrity. And
hmm
that's something that I've been talking about with my physicians and practitioners is that, by having a lack of documentation, the quality of the care could be questioned. And that's something that is going to be frustrating. I know that's frustrating to hear, but they're looking at the integrity, the
hmm
value. You don't want to devalue the work that was performed by saying very little about it, little to nothing about it sometimes. And,
Yeah.
we need to think of it from that perspective and not just, oh, this particular note reflects everything I did. I'm going to approve it and move on.
Yeah, and so in this decision table, there's a couple things. Under program integrity issues, like you were saying, it says copy and paste or cloning can lead to redundant and inaccurate information in the EHR. Using this feature can cause authorship integrity issues since documentation cannot always be tracked from the original source. Now, I
Mhm.
know that certain software that can be used, like Epic, for example. You can have that hover to discover. But think about the fact that when you have an outside reviewer coming in, or like a payer coming in wanting to review, more than likely you're not giving them access to your EHR or your EMR. They are getting,
Hopefully you're not.
yes, you are
That's
getting
changing, but
documentation. So how are they going to see who authored these things? And how are they going to be able to know, like, okay, they see documentation from Dr. XYZ over here, and it looks the same as Dr. ABC. Um, that's going to cause an authorship issue. Who did this work? But the other thing that they say in here is under best practices, ensure providers recognize each encounter as a standalone record. Ensure the documentation for the encounter reflects the level of service actually delivered. So I know that you've seen this in some of my audits that I've done for some of your projects in the past, Stephanie, when we
mhm,
worked together under doctor's management. But I like to heavily focus on pointing out the redundant information, as well as inaccuracies that come up in the medical record because of the use of copy and paste. So when I am auditing for that particular feature being used, that's how I kind of like to debunk the use of copy and paste when I see it being used incorrectly. I think
yeah,
there's
like
absolutely
the
benefits and use for it, but there is
mhm.
such overuse and inaccurate use of it, it causes such a problem.
Yeah. So one of the things I know that we've seen in the past is, for example, in the assessment and plan, the constant referring to the review of the same lab
Yeah,
results since 2022, and it's in
lab
every single
results,
assessment and plan.
conversations with family, other providers. I see
Hmm.
that a lot. Copied forward information saying start this medication, but when you go back and look, they've been starting that medication, like this is a hospital example, starting that medication for the past 5 days. Did you even look at this note? Did you
Yeah.
even review what you were copying forward for relevance and accuracy for this encounter? So that's where that's where I think the biggest issues
Hmm.
come from. Yes, it's a time saver, and there is a documentation burden, on providers, especially like I think of hospitalists, for example,
Hmm.
is where we see a lot of copy and paste used. And it can be a time saver, but are you really showing your work of the encounter, or are you just trying to save yourself some time because they're the same as yesterday? Um,
Yeah, that happens a
I,
lot. We hear
yeah.
that a lot in the sessions. And, one of the things that we need to highlight as well, and you touched on this a little bit, but I want to make it more clear, is that when this documentation is either copied and brought forward, or a lot of EMR systems have a button you can click and it just carries it forward for you. So when these things are used and is happening, you're only compliantly allowed to do that if it's your own documentation that you have authored personally. So a lot of times we'll have issues because we have different providers that are in a large group together.
Mhm.
In the hospital situation, we have one taking over the care from the other. We have different residents involved. One resident can't take the note of another resident. And I'll be asked, well, why isn't it okay? They have the same faculty that's overseeing them. You have to personally author the documentation that is being brought forward. And this is something where we've had clients push back. They do not like it being referred to this way, but it's looked at as clinical plagiarism.
Mhm.
And no matter how much you don't like to hear that as an organization, when you look up information from the OIG, CMS removes some of that language from what they have, but it's absolutely in reports from the OIG. That is how they're referencing it, because you're taking the documented work of someone else, bringing it forward and claiming it as your own. So it
Mhm.
doesn't matter if it's the same, you can't use that function at all. And this is something where workflow really becomes a large problem because we have situations, Michelle, where under the 2021 guidelines with the 2023 revisions, and how much were we told initially that that was going to help alleviate the administrative burden, right? And
Mm-hmm.
that's not really been the case. We have different EMR companies. It's very rare that we audit anyone and they've changed their structure from what they were under 95 and 97 guidelines. So we have templates staying exactly the same, or you and I were reviewing records this morning and talking about how there's so little information there
Mm-hmm.
that, the providers essentially undercoding their work just to go under the
Avoid
radar and get it
documenting.
off their plate. Yeah.
Yeah, and those were I'm sitting here like looking at the reason the patient is there and I'm like, this is all you did
Mhm.
for this scenario? Like this patient's in the hospital long term.
I
I
had an
understand
oncologist
things may
doing it.
not be, these were OB notes, for example, but they were in the hospital long term for very serious conditions
Mhm.
related to pregnancy. And it's like this is all you did to monitor this patient that you have admitted for preeclampsia. Like, I question.
Yeah. Well,
But
yeah.
that's an education opportunity for those particular providers, because that's not the answer. The
Mhm.
answer to the administrative burden of documentation is not less is best and just build the lowest level of service. Because when you're looking at the nature of the presenting problem, which is kind of old language, but still how we start forming that thought of medically necessary, medical necessity, but you're always billing level ones and have this absurdly limited documentation.
Yeah.
Why?
Yep.
What kind of care did you provide that patient? Like you said, they could be the best, probably one of the best physicians out there for OB, but I would never know.
Mhm.
you,
Yeah.
you know, so I couldn't
Well,
even
and
really tell what you did.
if you think about visibility, one of the things that is frustrating, and I've actually seen clients talking and back and forth administratively about patient complaints or family complaints. If you think about access to documentation through a portal, there's a
Hmm.
lot of times where as soon as that document is closed and signed off, that's available to them. They're able to see what that looks like. And if they know you spent an entire hour with them, but you say, for example, this oncologist I was reviewing, everything said PE no changes. I have no idea what prior physical exam was done that they're comparing that to. And each note I looked at said the same thing about the physical exam. So, where did that begin? When did
Yeah.
you actually put hands on or examine that patient? And when you're thinking about, any specialty, I don't think in this regard one is more complex than the other, or they all have their own areas of focus.
Yeah.
So it's not like one particular specialty is viewed as less than another, so they don't need as much. We should be seeing this. And that's something too when we look at the use of all of these different smart tools. Sometimes I'll be told, well, yeah, that template looks the same, but we don't have to document our exam anymore. We don't have to document our history. And you have to remember there's a difference between us no longer coding that and counting that towards a leveling of an E&M service and what is still required in the guidelines. And
Yeah.
it is still a requirement. Now, one of the
And
things,
just
go
because you
ahead.
don't code on it doesn't mean you don't document it. I mean, think about your patient sitting there
Mhm.
who may need to now go see a specialist. And what information does that specialist really have? other
Right.
than what the patient may or may not be able to relay to them based on prior visits. Because, as you know, it can be really difficult to
Hmm.
absorb all the information that is being presented to you when you're at the doctor, regardless of the specialty, whether it's
Yeah.
your primary care reviewing your chronic conditions or seeing a specialist for something very specific. So that continuity of care really is, being affected by
Hmm.
this thought that less is more when it comes to documentation. And oh, they changed the billing guidelines to reduce that burden. Well, they didn't reduce the need for your patient to know what happened during the encounter or for you to properly convey the complexity of your patient.
Yeah. And that really speaks back to that word integrity, or when we're
Mhm.
looking at not devaluing that particular encounter, what we can see about that.
And it's so frustrating because you do know that these providers work so hard, and you know that they are having their schedules packed more and more full, and there's nothing that administration is willing to do about it.
Hmm.
And it's I can understand that frustration. And it's just a bigger problem
Yeah.
than just, these CMS things or documentation integrity. It goes a lot further than just these limited notes that we're seeing.
Hmm. Yeah. Yep. Well, and one thing that I like to talk providers through when we are trying to understand why this is so important, right? Trying to get them to see the side because, like you said, it's very frustrating. But I think it's really important to think about the landscape in the way that the external reviews are taking place. So, a couple weeks ago with Sean and Eric on the podcast, we were talking about audits versus investigations. And
Mhm.
I find that a lot more practices are under investigations and they don't even realize it. They think it's an audit. And
Mhm.
when we look at the workflow and what typically happens now with these external investigations, they're not just asking for one note from multiple patients. A lot of times I'm seeing that they're receiving a request now for 10 patients, but they want the last 6 months, or they want the entire hospital stay for each individual patient.
Yeah.
And you had spoke to that tool in Epic that we see most often, the hover to discover, where you can see specifically where something is pulled forward. That can still be identified in a manual review because when they have multiple dates and they can compare back to back, they're able to see that. And I do that in my own reviews. When I have clients that don't have a system like that, I just take my snipping tool and work with it to compare two notes together to identify those similarities.
Yes, but what's problematic about that when you use the snipping tool is now the provider doesn't have that work attributed to the appropriate provider in their documentation because they are relying on Hover to discover to say
Hmm.
they pulled this from Dr. XYZ into their note today.
Yes.
And
Yeah.
that's what's problematic. And it's I just lost my
I know.
my
I'm
train of
sorry. I
thought.
threw a comment up there.
I know, I saw that. But like with all of these tools, I understand they're meant to be helpful and try to reduce some of that time it takes for documentation. But it just starts going too far
Mhm.
you know, as for how they're used. And another area that I see often misused is templates. Well,
Yeah.
let's is there something in here that
Yeah,
I
so Dr. Rosenstock put a comment here about pre-printed operative reports with checkboxes or blanks that are filled in with handwriting. It's very dangerous. All operative reports should be dictated as no two cases are alike. And,
Mhm.
I've actually had multiple legal defense cases I've had to work in this particular arena, especially with dermatology. They love to do this. I
Mhm.
actually have certain dermatologists I've worked with just last year. I thought it was this little tiny practice because they refused to use an EMR system. Their entire practice was extremely manual. They had probably triple the amount of staff they should have because they refused to get an EMR, but yet they were doing things like this and checking boxes. And yeah, there's ways to defend it. Obviously, it's reflecting the
Yeah.
care of the patient. But when we're talking about these bad practices or the way that tools are misused, it's because it's requiring a situation that has to be defended.
Mhm.
And we don't want to constantly have workflow that requires defense,
Yeah.
because that's going to happen more and more. The investigations are going on constantly from the government, from the commercial payers, and it's not something we want to play around with.
No, and what he specifically mentioned kind of goes right into what I was going to talk about with the use of templates.
Hmm.
I was doing a review recently, um, and it was for viscosupplementation, which is expensive.
Hmm.
That's an expensive drug. And as I'm reviewing these documentation, um, the encounters that were sent over for review, every single patient encounter is the same. And even though it wasn't, it was documentation sent over. I wasn't in the system to see where the documentation came from and things like that. I picked up immediately that this provider was using a template
Hmm.
for their note. Every patient was described to have the same kind of pain, the same kind of quality, the same kind of severity. There was nothing to show what was specific about that patient and their condition. And so that was a little concerning because now what we have is this string of patients that all have the same documentation.
Yeah. Well,
And
I had that with a surgeon before. It was
mhm,
bariatric surgery, and basically every note for every single new patient was 100% the same. And the
mhm,
only variation was if he added in an underlying diagnosis. But the worst part of all of that was even when they had an underlying condition, the way that he structured his note, it said, if the patient has this, then I did that. If the
yeah,
patient has diabetes, then I did that. And
yes,
he was frustrated with me because I actually failed him on it because every word was the same. And I was like, we've got to talk about this. You're not showing the individual care and examination of this particular patient. If they have that underlying condition, something has to be prompting them to come in and see you and want to pursue surgery and all of those things.
yeah,
And his thought process was, well, clinically I'm going to treat them the same. It's going to be the same protocol clinically. But we have to remember that there are a lot of guidelines and regulations in place that have to be followed when it comes
yeah,
to documenting care. And Michelle, one thing I want to just finish our time out with today is talking a little bit about tips and ways that we can help have open conversations that will help our providers come up with a solution. A
mhm,
lot of times we will come to an audit feedback meeting, for example, and have all of these issues there, or have a high volume of variances. But then what are we going to do about it? And,
mhm,
I just spent 2 weeks meeting one on one, or over 2 weeks meeting one on one with a lot of practitioners that are struggling in this particular area. They're all frustrated. They have very little time that is scheduled for them to be with the patient. It's supposed to include administrative time, and they just have, I think, a short 30-minute time at the end of the day scheduled for administrative time. So a lot of them are frustrated, and for them, these scores are going to impact, their bonuses, their salary, their raises,
mhm,
all of these different things. So one thing I'll tell you quick what I like to do. One thing that I did with this group recently is I would bring up the EMR system, share my screen, show them exactly what is the same. So show them in their own work what
Mm-hmm.
is not, compliant essentially. A lot of times they would understand as we look at the final version of the note, but some people were still struggling or they wanted to take notes to make sure they do it right after. So at that point, I would have them share their screen with me so we could look at the user side of the system. And
Mm-hmm.
Michelle, I know when you were working in a hospital system, you did that a lot. You really worked hard to understand the
I did.
workflow in Epic. And,
Yes.
can you talk through some of that, how you use that knowledge or even learned from your providers? It's not to mean that we
Yes.
know every solution.
Exactly. And that I think is one of the biggest tips that I would have as you go to meet with a provider who seems to be struggling with this type of documentation. Listen to them. Listen to what they are telling you because often that is going to help you guide them to what
Mhm.
they need to do. Also, explain to them that these are meant to be structures. Form a structure of your note, not completely replace an entire element of your documentation. It's supposed to give you a framework where maybe you're not having to type out, the same words every single time, but not be like your entire assessment and plan. It may be that for a certain condition, like maybe a cold or something, or even like a joint injection, the same thought process might be going on, but what you're not accounting for are the uniqueness of your patients and how each patient interaction is unique. So I think that one, understanding what the provider is doing, having an understanding of their workflow, but then also independently from what they're doing, figure it out for yourself so that you can go to them and say, okay, I see you're doing this, but why don't we try this? So, for example, a provider overusing copy and paste, maybe we can show them how to create a framework out of templates
Mhm.
instead, which to me would be far better than a fully copied note, because if you're giving them a framework that they can then add onto for each unique patient, um, but having an understanding but also listening to what they're doing, seeing what they're doing, really can give you perspective, because some may not realize they're using that tool
Mhm.
incorrectly or realize that there are other options available to them which may be better suited for what they need, like a smart phrase or a template or things like that.
Yeah, yeah, I agree. And, for me, because we usually, whenever we're in a system, we should have read-only access and we
Hmm.
should only be looking at the final version of the note. So it helps us to listen to them and to watch them working through the system because sometimes I'm surprised to find, for example, I've found issues with different ways that injections are showing up in NextGen. I was working with a rheumatology client and the wording was wrong for the CPT code. So I'm meeting with the physician and they're confused because they know the injection they did, but then I'm confused because the language isn't showing that in the procedure note.
Yeah.
So it's making sure that we find how it's set up. There's so many times that even the result of an audit, you don't just look to your provider at
Mm-mm.
documentation, a coder, if there is one, you have to look at the EMR system. And to your point, Michelle, you have to fully understand, how that is working, basically,
Yeah.
how that is
Yeah.
structured, how they're using it, all of those things like that.
Hmm. Yeah. To be able to effectively assist them and help them change a workflow. Um, I know I was working with Epic at the time, and it was extremely it was extremely difficult to get answers or try to get help out to a
Mhm.
provider. So I basically was like, well, I guess I got to do it. Um, and
Yeah.
it really changed a lot of things once I started diving into their workflows and their side. of the system.
Yeah. All right. Now, before we go, Michelle, I just wanted to talk quickly about the Etsy shop that is open now. So, Michelle has been giving me a lot of input on this. I always go
It's
back and
fun.
forth.
It looks fun.
It is fun, but you know me, I'm always like, is this too corny? Is this too old lady-ish? Because I love Murder She Wrote and JB Fletcher and all of
Yeah.
these different hobbies. But
Maybe I'm not the best person to ask because we have the same hobbies. Like, I don't know.
I
We're
know.
both old ladies.
I know. I enjoy it though. I love it.
Yep.
But if you are interested, visit S. Allard Consulting on Etsy, and there's just some fun merch out there to wear during your workday or put out in your office space. I like to put different things out that are fun, that aren't just the same day in and day out, boring type things that we're looking at. So check that
Yes.
out if you're interested, and we will see you back next week.